inside out. And everybody can see that, right?
Yep, so far.
Okay, good. Thank you very much. Okay, so the first part of the lecture guide just kind of does a little bit of review. You should, again, remember back to your anatomy and physiology that your endocrine system is controlled by a feedback system, and that being a negative feedback system. So if you turn to your second page of your notes and actually look at the hypothalamus, the question it poses is, do you need corticosteroids or not? Then that goes to the pituitary, and either you say, yes, I need some, or no, I don't. If you say no, then it does not release ACTH or secrete it. If you say, yes, I do, it secretes ACTH, it goes through the blood system, and it goes down to the adrenals. And then in that case, it secretes corticosteroids, which is what you learned last week. Then it increases the corticosteroid and hydrocortisone in the bloodstream. The question goes back to the hypothalamus. Do we still need more steroids? This time, it says no, and it stops the production of ACTH. And that system stops until you need more. And that's pretty much how all of the hormonal systems work. So, stressors that result from pituitary gland dysfunction. First, where is the gland located? Well, again, if you can remember back to A&P, it is located in a depression within the skull in the sphenoid bone called the sella tertia. And that is where it resides. You have two lobes to the pituitary. You have an anterior and a posterior pituitary. Remember, the anterior pituitary actually makes these hormones, and the posterior pituitary only stores those two hormones. So in the front, you have LTH or prolactin, you have growth hormone, you have thyroid stimulating hormone, follicle stimulating, luteinizing hormone, adrenocorticotropic hormone, and then you have melanocyte. For the posterior, we have antidiuretic hormone or vasopressin, which is a very potent antidiuretic.
Hey Lisa, we can't see the PowerPoint going forward. We just see your canvas.
I wonder why. Okay, let me stop sharing. Now, can you see that one? Probably not. Hang on. All right, let me do share screen, Lisa. Can you see that?
Yep.
Now you see the pituitary on there?
Yep.
Okay. Let's see. So, do you see that?
Yep.
Okay. All right. So let's go back here. So here was just talking about the sella tertia, and it located in that sphenoid bone. And here's your anterior pituitary and your posterior pituitary. Okay. This is a little bit of a picture like you have in your notes. You can see it's divided into anterior and posterior, and it just is giving showing you again what those particular hormones do within the body and where they're located. So the first thing we're going to talk about are stressors that cause pituitary disorders. It might be a tumor of the pituitary, some type of trauma to the area, a vascular lesion where it's interfered with blood flow to the pituitary, some type of infection. Maybe you've had radiation therapy for something and it's affected the pituitary, or a surgical removal. So the first one is overproduction of growth hormone. This is the most common cause as a benign adenoma of the somatropes, and it causes gigantism or acromegaly. Gigantism is before those seals close, or after those seals close, before the seals close, excuse me, I'll get it right here on that. I have a 50-50 chance I'll get it right, don't I? And it causes excessive skeletal growth and soft tissue in children. So up until the time of puberty, once those seals close, then we would progress to acromegaly. So for gigantism, we're looking at a body frame of the upper 7-footers to 8-foot plus for gigantism. So gigantism's in children, acromegaly is in the adult, and that would be after those seals close. Signs and symptoms. This is going to be signs and symptoms of acromegaly, because we know what the signs and symptoms of gigantism are, is that you're excessively tall and large. So increase in their connective tissue, cartilage, a thickening that occurs of the hands, feet, and face. Neurologically, they can have a headache, visual disturbances, and those really are not from excessive hormone, but from the tumor compression. So increase in connective tissue, cartilage, growth and thickening of their hands, feet, and face. And then neurologically, they can have a headache, visual disturbances, and those are all due to pressure from the tumor. This is just showing you a picture of a gentleman. This might have been a high school graduation picture. And then progressively over time, you can see that he acquired acromegaly. And over the years, things just became coarser. So this very fine, refined features here. And then you can see here, I don't know what his age would have been, maybe 60s, late 60s. And you can see how coarse, see how broad his nose got, his chin, forehead, etc. Once these changes occur, even if we correct the acromegaly, they still stay. You cannot reverse those. So what we really want to do would have been to have found it in this stage versus clear back here. Again, you can look at this slide when I open it up. Diagnostics over the years, they have an increase in their glove, ring, or hat size in no relation to the size of their body. So if you even look at the picture here, it doesn't look like he got, I mean, I'm sure over the years you gain a little bit of weight, but it doesn't look like he became morbidly obese or anything like that. So it would not be that these things occurred to increase in their physical size. It's due to the increased connective tissue and stuff that caused the glove, the ring, the larger hat size that would occur. If you did lab work, they would have an increase in the amount of growth hormone that is present. Remember that growth hormone antagonizes the action of insulin. So due to that, they have an increased glucose. And then your CT and MRI, those do show those physical changes that are occurring, that increase in the connective tissue, etc. Complications from having too much growth hormone. Complications with acromegaly might be infertility. So if that's an issue, a lot of times they'll go through the whole endocrine system to make sure that there are no issues. Diabetes, it does impede glucose take up by the cells. High lipid levels. Growth hormone mobilizes fat. Remember, it's antagonistic of insulin. So between those two things, it can cause cardiac disease and high blood pressure. So those are all things that a person can live with. But the biggest thing on acromegaly is that the physical changes will not reverse themselves, even if you can get the infertility or the diabetes or the lipid levels under control or the cardiac disease. The physical changes are already there. In gigantism, again, nothing you could do to reduce their body size. And oftentimes, what they have for a complication of gigantism is cardiac failure. So that's usually what takes their life. This is Andre the Giant. Andre the Giant did suffer from gigantism. So he might be somebody that you're familiar with. Treatment, surgery, irradiation, or freezing. So cryosurgery. Surgical removal would be a hypophyseectomy. Lifelong replacement of hormone stimulation by the anterpituitary. So you would need those glucocorticoids, thyroid medications, maybe sex hormones. Letter D, there are growth inhibitors that you can take, medications. And letter E, remember that the skeletal changes are not reversible. Nursing implications, be alert to excessive growth in children. Adults would be that increase in hat, ring, or glove size. Problems they might have might be self-image disturbances, emotional support for it, and teaching about the medications that they might need to take. For excessive growth in children, if your spouse is 6'8" and you're 5'10", having an excessively tall child, somebody that's on the growth chart, is not uncommon. They still will watch their growth to make sure that it's not way too much, and then could investigate a little bit. But if your family, the tallest person in your family is 5'9", and your kids are already in the 120th percentile for height, there might be some testing that gets done to see why your child is growing so quickly. Then I have a picture there in your notes of a young lady versus the man that I had in the PowerPoint. You can see, again, fairly refined features, a very nice, attractive young lady, and then see how coarse her facial images and her hands and stuff got as her acromegaly progressed. And we're talking about pictures that are fairly old here. So the likelihood with modern diagnostics, those kind of things, of gigantism occurring in the United States and acromegaly not being caught fairly early are probably slim to none, unless you are off the grid and you do not seek out any type of health care. That's probably the only way you're going to see these two things progress. Okie doke. Underproduction of growth hormone. This is called pituitary dwarfism. The signs and symptoms are short stature in children. In adults, there are real no changes except there may be some fragility to bone. So you might have some type of compression fracture or something like that might occur. Treatment for them would be Somatrem or Humatrope. These are synthetic growth hormones. The cost is somewhere between $10,000 to $20,000 a year. It can be IM or sub-Q. Teaching for these folks would be to expect a 3 to 5 inch growth in about the first year, less after that. Watch for too much growth hormone. There may be a need for annual bone assessments just to watch that growth. This is something that can also be given, again, it's something that you have to work through as a parent, but if you have kids that are just naturally short and you want them to be just a little bit taller, you can have them take growth hormones to get that possible 3 to 5 inches of growth. You have a young man that's 5'6" and you want him to at least be 5'9", 5'10", growth hormone could help with that. Again, that'd be something that you and your pediatrician would have to work through. Overproduction of gonadotropins, too much LH or FSH. Signs and symptoms are really more related to the presence of the tumor. You're not really going to know if you have too much LH or FSH. Underproduction of gonadotropins. For this particular one, the first one is not going to be infertility, but menstrual irregularities. Decreased sexual desire, and then infertility. So those are for women. So menstrual irregularities, decreased sexual drive, and infertility. Signs and symptoms of men would be delayed puberty, testicular atrophy, decreased sperm production, loss of libido, and impotence. So if you look at the symptoms between men and women, who do you think is going to see the doctor first?
Men.
You got it. Women, menstrual irregularities, decreased sexual drive, you may not know you're infertile if you're not trying to get pregnant. So women take those first two in stride. Men, however, you start seeing those. Mothers, you start seeing your son or husband's fathers that see that sons maybe aren't producing secondary armpit hair, hair on their legs, those kind of things, probably are seeking out the pediatrician to see if there's some type of delay in that. So a lot of these things would get caught probably a little earlier for the male than they are going to be for the female. And again, the treatment is easy enough. It's just oral replacement. Okay, hypopituitarism. This is of the anterior pituitary, and then the rest of our lecture notes will be based on the posterior pituitary. So etiology for some type of anterior pituitary issue would be a lesion or destructive process in or near the pituitary. We call Sheehan syndrome. This is a postpartum necrosis. The pituitary suffers an infarct during or almost immediately after some type of postpartum or delivery procedure. Signs and symptoms: lethargy, fatigue, intolerance to cold, weakness, loss of libido, impotence, and infertility in women. Very hard to diagnose, especially on the postpartum mother, because of postpartum blues, having a newborn at home, etc. A lot of these symptoms coincide with that. So again, a lot of times diagnosis of this particular issue is going to be delayed. Diagnosis then might be a decrease in pituitary or the target hormones. And the other signs and symptoms you can see above there. Treatment for these folks is going to be a lifelong replacement and thyroid hormones, sex, and growth. Nursing implications would just be education in regards to the medication themselves. Okay. All right, so the first thing is hyperfunction of the posterior pituitary. This is due to an increased release of antidiuretic hormone. Remember, the normal function of the antidiuretic hormone is for water regulation, and it is a potent vasopressor. It increases the plasma osmolality, and it stimulates ADA production. ADH production. It results in a more dilute serum and concentrated urine. And in the absence of ADH, the antidiuretic hormone, you are going to get Stimulation of that water is not going to be saved by the kidneys, and it results in a more concentrated blood and a more dilute urine. So you can highlight that. You do have to understand that mechanism. But when we say antidiuretic hormone, it means that you are not peeing. So that fluid is being accumulated. ADH causes the loss of potassium. Without ADH, excessive potassium is going to be retained. So the first thing you want to look at is factors that affect ADH release. So factors that stimulate ADH release and conserve water would be water loss or blood loss, acute infections, medications like morphines, anesthetics, barbiturates, pain, trauma, some type of surgery or maybe an accident or emotional stress. So almost everything that patients get admitted to the hospital for are going to cause you to retain fluid, which makes sense that a lot of your patients do complain of edema, fat little fingers, fat ankles, swelling of their feet, those kind of things when they're in the hospital. Things that inhibit ADH release and promote diuresis, water overload or blood volume, patient being cold, somebody who's abusing alcohol, diabetes insipidus, and CO2 inhalation. So the first one we're going to talk about then is syndrome of inappropriate antidiuretic hormone. The normal response to a decrease in your serum osmolality is to decrease in the secretion of ADH. In SIADH, that normal feedback mechanism for antidiuretic hormone fails, and the level of antidiuretic hormone is sustained or is excessive, causing excessive water retention in the body. So you can see it's also called Schwartz-Barter syndrome. The normal feedback system fails, so you get excessive amounts of ADH produced, which means that you are going to retain fluid. When you retain fluid, you don't retain more sodium, so it's like putting the salt shaker in the swimming pool, and it's not enough sodium to make it equal parts. Okay, but if you drain the pool, but keep the salt shaker there, eventually you'll get down to less water, that the salt shaker goes back to the normal amount of sodium. So here it's not the lack of sodium, it's too much water diluting the pool. Okay, if we get rid of some of the water, that hyponatremia or that low sodium should go back to normal. It can be a chronic problem of the pituitary for some folks. It is often, though, temporary or self-limiting. And oftentimes, if we can remove the cause, we can remove the problem. Who's at risk for SIADH? People that have CNS disorders, head injuries, brain tumors, encephalitis, meningitis, those kind of things can have SIADH. So those would be temporaries. Medications like chemotherapies can predispose you to SIADH. Again, those would be temporaries, hopefully. Tumors, there's your small cell lung CAs, can cause antidiuretic hormone. Hopefully we could remove the tumor and that would be temporary. Your anesthetics, pain medications, infections, all of those hopefully would be temporary. And once those got remedied, it would go away. Clinical manifestation, remember sodium levels that fall rapidly will cause more symptoms. Clients with chronic hyponatremia may not display symptoms even at levels of 115. So, our normal is up in that 135 range, but they're living with a low chronic hyponatremia. So you may not even see some of the signs and symptoms till it gets even lower than that. So if we do have a sodium level that falls rapidly, some of the signs and symptoms are anorexia, nausea, vomiting, and abdominal cramps, finger pit edema over the sternum, intake is greater than output. Weight gain without obvious edema because the water is inside the cells versus outside. Neurologically, you might see lethargy, headache, personality changes, seizures, pupil changes, coma, and respiratory arrest. So it is not something that we treat lightly. We do want to make sure that we remedy that hyponatremia. Labs, the urine osmolality will be higher than serum. So in other words, we'll have very dilute blood, but very concentrated urine. What do we do for it? Sodium replacement would be 0.9, 0.45%. Foods that are high in sodium. 3 to 5% sodium, like Riders, and you do have an infusion sheet on that at the back of your notes. There's a clinical snapshot or a clinical tip on page 13 on how to administer hypertonic saline solutions, 3 and 5%. So again, I would read over that. Either you'll have a question on it on your test 5 or on your final. Diuretics, that decreases some of the water, but remember where water goes, so does sodium and potassium. So you do have to watch that you don't have too much of a loss of that. And then of course, potassium is probably going to be given due to the loss of antidiuretic hormone and also diuretics. Okay. Nursing care then for these folks would mean maintain a fluid balance and take an output weight checks. Due to the retention of fluid, they can gain, 6 to 11 pounds or so or more. Frequent neuro assessments, especially as the sodium decreases or gets to less than 120, they are at risk for seizure activity. Putting the head at no more than 10 degrees elevation does increase the left atrial filling pressure, and somehow somebody figured out that decreases the release of antidiuretic hormone. We would administer and monitor electrolytes. Medication that they can be put on might be declamycin. Declamycin actually blocks the effects of antidiuretic hormone in the kidneys. And then lithium blocks ADH. But remember back from your mental health that lithium does cause a lot more side effects. So our drug of choice here would be declamycin, and then lithium would be our second choice if that was not working. For people that have it as a chronic problem, they just learn to live with their low sodium levels. In times when they're losing a lot of fluids or that, they can take salt tablets, those kind of things. They just have to remember that those can be very irritating to the stomach. So they might have to take them with food, etc. But there are supplements that they can take if they can tolerate them. Okay, hypofunction of the posterior pituitary. This is a decrease in the release of antidiuretic hormone, and we call this diabetes insipidus. It's a transient or permanent loss of the ability to secrete vasopressin or ADH. And so their clinical manifestations can be large quantities of urine with a very low specific gravity. So they would be peeing out, maybe 1 to 4 liters if it's mild a day, or 5 to 40 liters per day if it is severe. They would have a very low specific gravity, meaning the urine probably is clear like water. It's really not concentrated, so it has no color to it. Other signs and symptoms obviously would be a low blood pressure, increased heart rate, increased thirst, and poor skin turgor. Causes, secondary, would be head trauma, vascular accidents. Surgery usually is very self-limiting, and that is the more common cause, a secondary issue. Primary issue might be some type of tumor, inflammation within the pituitary or the hypothalamus, and encephalitis is fairly rare. Highlight this. Remember, if you end up working in some type of neurological unit, the post-op outputs in neurosurgical patients with some type of brain surgery, head trauma, if it's 500 mLs in 2 hours, that's an excessive amount, especially if you're not giving any diuretics. And it's not uncommon for them to have that, but it should be one of those self-limiting causes that once they've recovered from their surgery, that it should get better. There is another possible cause for diabetes insipidus. This would be, it's nephrogenic, not neurogenic, nephrogenic diabetes insipidus. It's fairly rare. It's not an antidiuretic deficiency. It's the inability of the renal tubules to actually reabsorb water. It's a genetic issue. So, number 4, or D, we can do a water deprivation test. Oh, excuse me, 4 is a drug related. If you look, diabetes insipidus can be related to lithium and declamycin, meaning you're taking too much of those medications and they interfere with the kidney's responses. So we said that it's kind of like Danielle, you had the Cushing's person. They got Cushing's because of their large corticosteroids they were taking. Again, here we could get diabetes insipidus due to the large doses of lithium or declamycin that the patient was taking. And that one's not on there, but again, that should resonate that if you're taking too much of those 2 medications, that it could cause you problems. Okay, D, the water deprivation test. This is a test where we're going to withhold water for about 8 to 12 hours or until 3 to 5% of your body weight is lost. We want to make sure that they're not sneaking water because they're going to be very thirsty, polydipsia with this. So you don't want them sneaking to the bathroom to get a drink of water, anything like that. Once they've lost 3 to 5%, we're going to monitor them very closely so that they don't drink anything. Then what we're going to do is administer vasopressin. And if they're able to concentrate urine, then we know it is a ADH problem versus a kidney problem, a pituitary versus a renal problem. So if you give ADH and they still can't concentrate urine, you know it's not a pituitary issue. It's a renal issue. If you give the medication, they start concentrating urine now and don't have the large urinary outputs, then you know it was a pituitary issue. Treatment and nursing care. Ensure adequate fluid intake. So fluids, monitor them closely. Intake and output should be fairly equal now. They're probably going to need IV fluids, and if they diurese, they're going to need increased fluids. Secondly, we monitor their lab work, their urine-specific gravity. If decreased, their meds are not working, then they're going to have a decreased urine-specific gravity. Serum osmolality and sodium will be increased if their fluid intake is deficient. You want to observe for water intoxication. It can occur if patients are receiving excessive amounts of ADH. You will see edema around the eyes, fingers, ankles, sacrum, cerebral edema, even with convulsions. You want to watch for dehydration, monitor their weight. 1 liter equals 1 kilogram. Adjust their fluids as needed. You want to monitor their nutritional status. Remember, if they're taking large amounts of fluids because they have polydipsia, then their appetite can be suppressed. And then watch their labs. You want to watch their protein counts. Emotional support for these patients, again, due to what could be causing their issue, can be upsetting to them. Patient teaching, medications, they're essential that they take them at prescribed times and monitor for effects. They need to report diuresis that's not relieved by their next dose of medications, especially if they continue thirst in the absence of excessive urination. Fluids as needed. They want to monitor their urine-specific gravity and the importance of follow-up care. So these people really need to be followed by an endocrinologist. 8, medications of the posterior pituitary. One of those is vasopressin TAN8. This is an injection. It also stimulates peristalsis and it causes vasoconstriction. So increased doses can cause, due to the vasoconstriction, can cause angina, high blood pressure, and MI. Our second one is desmopressin acetate, or DDAVP. It can be given intranasally, orally, or parenterally for prevention or control of polydipsia, polyuria, and dehydration caused by diabetes insipidus. It's caused by a deficiency of posterior pituitary ADH. What else do we give DDAVP for? Does anybody know? So DDAVP, or desmopressin acetate, can also be given for long-term therapy, but it can be given for bedwetting. So these are for children. They take it at night, and it actually shuts down the production, and then they don't wet the bed at night. Now, you wouldn't continue giving it throughout the day because you want them to go back to their normal production and functioning of urinary output, etc. But if you have a bedwetter, you can actually give this intranasally, or there's small little pills that they can take if they're old enough to take a pill, and it will actually shut down production so that they don't wet the bed at night. So that you may see those in some parenting magazines, those kind of things, that they can be given for bedwetting. They can also take desmopressin acetate for this particular problem, for diabetes insipidus. Okay, and the very last thing, and I'm going to finish this out, and then that way we don't need to worry about anything after class tomorrow, but the review. The surgical removal of that posterior pituitary would be, or part of the pituitary would be, a transsphenoidal hypophysectomy. It's a partial or total removal of the pituitary. We remove the tumor, We can halt progression of a macromegaly is another reason, or we can do palliative care for metastatic cancer of the breast or of the prostate. Forms of pituitary destruction or removal would be surgical removal, and that's what we're going to talk about, or irradiation or cryosurgery. This is what it looks like. This is a hypophysectomy. They've come up above the gum in through the nose here, or I've also seen the approach where they go up in through the oral cavity, up underneath between the tooth here, up in here and go in this way, or they can go through the nasal cavity and go straight back. Surgical preference, I have no idea why they do one over the other. Preoperatively, we want to provide for good emotional support, teach them that their head will be wrapped. They'll probably have raccoon eyes because blood and drainage will calm down around the eye area, so they'll be black and blue, and they need to have cortisone. Cortisone helps them deal with stress, and we're going to be disrupting that process here for a while. Postoperatively, for microsurgery, check for signs and symptoms of cerebral edema. Those are the opposite of shock. We have a decreased heart rate and an increased blood pressure and pupillary changes. Head of the bed should be at 30 degrees. It decreases the pressure on the sella tertia and decreases headache. We can do low dose pain medications. We want to prevent cerebral spinal fluid leaks. So we teach them not to cough, sneeze. And you say, how do you do that? But I know you've all been out in public where you didn't go, achoo, you went and try to suppress it. And that's what they need to do. Nasal packing will come out after about 24 hours and they will feel 100% better. I don't know if you've ever been around a family member or anybody who's had sinus surgery and where they pack the nose, or if you've had a nasal bleed and they pack the nose. It's miserable. Most of them will tell you they'll never have the surgery, or they would have never done it if they'd known it was that miserable. Once the packing comes out, they feel much better. Halo sign test. That would be checking any clear drainage from the nose for glucose, and that indicates cerebral spinal fluid leak. Next, we want to prevent separation of that sella tertia. So we teach them no bending forward. You would need to squat down, no sneezing, coughing, brushing their teeth, blowing or picking your nose, no straw or Valsalva. It puts too much tension on that surgical area.
How long can they not brush their teeth for?
I would say till that surgical incision heals. So maybe till they're seen by their doctor. They could use Paradex washes, those kind of things. You could use a soft sponge or something on the area, but have you ever brushed your teeth and the toothbrush slips and it jams you in your upper gum? That's what we don't want to happen. So that's why they tell them no brushing their teeth. Signs and symptoms of meningitis would be elevated temp, irritability, severe headache. And if they develop some type of meningitis, of course, they're going to need antibiotics, again, bed rest, those kind of things, because we don't want any type of brain abscess. If they've had complete removal, remember they're going to have deficiencies of the anterior lobe hormones, so they're going to need thyroid replacement, large doses pre and post of cortisone to prepare for the stress and the loss of the cortisone. Sex hormone replacement, counseling. Remember, they may go through a lot of highs and lows. When you disrupt the endocrine system, there can be a lot of depression, those kind of things. Remember, it is not their significant other that is causing the problems. It is the hormonal fluctuations. So good teaching with that. And then teach them lifelong replacement. Like we said, some of the sex hormones and stuff, you don't necessarily have to replace, but they will have to have thyroid and cortisone replacement. Diabetes insipidus, remember, is a common postoperative problem. It eventually should return to normal. It will be a permanent thing if there was a complete removal of the gland. So again, they would take replacement medications to prevent the diabetes insipidus. Then the next couple of pages just is how the hypothalamus regulates body functions. And then there is your clinical tip on your 3 or 5% sodium chloride production. Okay. Before Mrs. Rose comes on and does her review, do you have any questions about adrenal for me? There are some adrenal questions in your